Welcome to StudyNeuro. In this lecture, we examine the biochemical diagnosis of hypocortisolism in pituitary tumors, focusing on cortisol testing, interpretation, and common diagnostic pitfalls. The central clinical problem is recognizing inadequate cortisol production when pituitary disease disrupts adrenal corticotropic hormone secretion. This matters because adrenal insufficiency may remain subtle until physiological stress exposes inadequate adrenal reserve. Accurate biochemical assessment therefore guides safe glucocorticoid management. This lecture focuses on the hypothalamic pituitary adrenal axis and how cortisol production is regulated. We will examine how pituitary tumors and sellar disease can produce central adrenal insufficiency and how morning cortisol and adrenocorticotropic hormone concentrations should be interpreted together. We will also discuss dynamic testing, particularly the adrenocorticotropic hormone stimulation test, while recognizing important biochemical and clinical pitfalls. Finally, we will distinguish central disease from primary adrenal disease and glucocorticoid-induced suppression. Hypocortisolism means inadequate cortisol production. In patients with pituitary tumors, it usually reflects secondary or central adrenal insufficiency caused by inadequate adrenocorticotropic hormone stimulation. Tumor compression, surgery, radiotherapy, pituitary apoplexy, and other sellar disorders can impair this pathway. The presentation may be subtle, but the deficiency becomes particularly important during physiological stress. Biochemical assessment therefore helps determine whether glucocorticoid replacement is required. The hypothalamic pituitary adrenal axis regulates cortisol production through a coordinated hormonal pathway. The hypothalamus releases corticotropin-releasing hormone, which stimulates the pituitary to release adrenocorticotropic hormone, and this then stimulates the adrenal cortex to produce cortisol. Cortisol secretion follows a pulsatile and circadian pattern, with the highest concentrations occurring in the early morning and the lowest at night. Cortisol also provides negative feedback to both hypothalamic and pituitary hormone secretion. Chronic adrenocorticotropic hormone deficiency causes adrenal atrophy and impaired cortisol production. This is a key physiological consequence of prolonged central suppression. Central adrenal insufficiency develops when pituitary or sellar injury reduces adrenal corticotropic hormone secretion. Reduced stimulation of the adrenal cortex eventually produces cortical atrophy, followed by reduced cortisol production. The process can therefore be understood as a progressive chain from pituitary injury to hormonal deficiency and finally impaired adrenal function. Mineralocorticoid production is usually preserved because it is primarily regulated through the renin-angiotensin system rather than by adrenal corticotropic hormone. Central adrenal insufficiency can present with relatively nonspecific symptoms. Patients may report fatigue, reduced exercise tolerance, weakness, anorexia, weight loss, nausea, abdominal discomfort, vomiting, or dizziness, particularly with postural symptoms. Examination may reveal hypotension or postural hypotension, while biochemical abnormalities can include hyponatremia and, particularly in severe deficiency, hypoglycemia. The presentation can be easily overlooked because none of these findings is specific. Clinical suspicion therefore remains important. Certain findings should increase suspicion for central adrenal insufficiency in a patient with pituitary disease. These include a known pituitary macroadenoma, multiple pituitary hormone deficiencies, previous pituitary surgery or sellar irradiation, and pituitary apoplexy. New symptoms developing after treatment of a pituitary lesion are also important. The absence of dramatic symptoms does not exclude central adrenal insufficiency. In practice, the pituitary ostomy provides essential context when apparently nonspecific symptoms or biochemical abnormalities are encountered. The morning serum cortisol concentration is the principal initial biochemical assessment because endogenous cortisol normally reaches its highest concentration in the early morning. Testing is generally performed around 8 to 9 in the morning, ideally before exogenous glucocorticoid administration when clinically appropriate. Interpretation requires attention to the clinical setting, laboratory assay, and recent glucocorticoid exposure. The important point is that morning cortisol is an initial assessment of endogenous cortisol reserve, rather than an isolated diagnosis in every patient. Intermediate morning cortisol concentrations require further assessment rather than immediate interpretation as either normal or abnormal. In the supplied material, a morning cortisol between 3 and 15 micrograms per deciliter, equivalent to 83 to 414 nanomoles per liter, leads to consideration of a corticotropin stimulation test. A stimulated peak below 18.1 micrograms per deciliter, or 500 nanomoles per liter, supports adrenal insufficiency according to the stated criteria. These thresholds must still be interpreted according to the assay and laboratory context. Adrenal corticotropin hormone should be interpreted together with cortisol. Physiologically, when cortisol falls, adrenal corticotropin hormone should rise. Therefore, a concentration that appears normal may actually be inappropriately low when cortisol is deficient. This distinction is particularly important in central adrenal insufficiency, where the pituitary fails to provide an appropriate hormonal response. Never interpret adrenal corticotropin hormone in isolation. The relationship between the hormone and cortisol provides the clinically meaningful information. The adrenocorticotropic hormone stimulation test evaluates the ability of the adrenal cortex to respond to synthetic adrenal corticotropic hormone, also called concentropin. The principle is straightforward. Stimulation of the adrenal cortex should produce a rise in cortisol. The supplied protocol uses 250 micrograms of concentropin intravenously or intramuscularly, with cortisol measured before and after stimulation. An inadequate cortisol response supports adrenal insufficiency, but interpretation should use validated, assay-specific cortisol thresholds. An important limitation of the adrenal corticotropic hormone stimulation test occurs early after pituitary injury or surgery. Adrenal responsiveness may initially remain preserved, despite newly developed central adrenal insufficiency, because adrenal cortical atrophy requires time to develop. A normal stimulation test can therefore miss recent-onset central disease. The result must be interpreted in relation to the timing of the pituitary insult. This is a crucial diagnostic pitfall. Other dynamic tests can assess hypothalamic pituitary adrenal axis reserve. The insulin tolerance test uses insulin-induced hypoglycemia to stimulate adrenal corticotropic hormone and cortisol, providing an assessment of global hypothalamic pituitary adrenal function. But significant hypoglycemia requires close monitoring, and the test should be avoided in patients with important seizure or cardiovascular risk. The metyrapone test inhibits 11-beta hydroxylase, lowers cortisol, and evaluates adrenal corticotropic hormone reserve through feedback activation. Both require appropriate clinical expertise. Several factors can distort cortisol interpretation because most circulating cortisol is protein-bound. Changes in cortisol-binding globulin can therefore alter total cortisol without producing an equivalent change in free cortisol. Estrogen therapy and pregnancy increase cortisol-binding globulin and total cortisol, whereas severe illness, liver disease, malnutrition, or protein loss can reduce it. After pituitary surgery, hypothalamic pituitary adrenal function may also be temporarily impaired. Interpretation must therefore consider the patient's physiological and clinical context. Acute illness and exogenous glucocorticoids introduce further challenges. Physiological stress normally increases cortisol production, so a cortisol concentration that appears normal during severe illness may still be inappropriately low. Exogenous glucocorticoids can suppress both adrenocorticotropic hormone and endogenous cortisol production. Always establish the drug, dose, route, duration, and timing of the last dose. These details can substantially change the interpretation of biochemical testing. The key distinction is that central adrenal insufficiency causes low cortisol with low or inappropriately normal ACTH, while primary adrenal insufficiency causes elevated ACTH and often aldosterone deficiency with hyperkalemia. Exogenous glucocorticoids can also suppress ACTH and cortisol, but aldosterone is usually preserved.
Hyperpigmentation points more toward primary adrenal insufficiency and is generally absent in central disease.
In conclusion, central adrenal insufficiency is an important consequence of adrenal corticotropic hormone deficiency in pituitary disease. An 8 to 9 a.m. serum cortisol provides the principal initial biochemical assessment, but it must be interpreted with adrenocorticotropic hormone, clinical context, medications, and assay characteristics. Intermediate morning cortisol values generally require dynamic assessment. The adrenocorticotropic hormone stimulation test evaluates adrenal responsiveness, although it may be misleading soon after new pituitary injury. Suspected adrenal crisis remains a clinical emergency, and treatment should not await laboratory confirmation. Thank you for learning with StudyNeuro. The platform provides high-yield neuroscience education and clinically focused teaching for those interested in neuroscience and neurosurgery. You can follow StudyNeuro across YouTube, Facebook, TikTok, Instagram, and X for additional educational content and clinical pearls. Like, comment, share, and subscribe to support the channel. Thanks for watching, and stay tuned for more.